Good afternoon everyone. So welcome to the fourth lecture in this series of acid-base disturbances. In last lecture we discussed about normal anion gap metabolic acidosis, and in this lecture we will be discussing about high anion gap metabolic acidosis. In high anion gap metabolic acidosis, from our previous lectures we know that we have a mnemonic known as mudpiles. M is for methanol, U is for uremia, D is for diabetic ketoacidosis, P is for propylene glycol, I is for INH and iron, L is for lactic acidosis, E is for ethylene glycol, S is for salicylates. Now this classification is fine for remembering the causes, but for evaluation of hagma we have a better functional classification by name of kult, K-U-L-T. K is for ketoacidosis, U is for uremia, L is for lactic acidosis, T is for toxins. In toxins I will have all toxins: methanol, propylene glycol, ethylene glycol and salicylates, right? So we start with ketoacidosis. When we talk of ketoacidosis, we are just not talking about diabetic ketoacidosis, we are also talking of starvation ketoacidosis, we are talking about alcohol related ketoacidosis, and finally we are definitely talking about diabetic ketoacidosis. So what is ketoacidosis? It is acidosis in blood with presence of ketone bodies, that is beta hydroxybutyrate and acetoacetate. Both these ketone bodies are present in all three types of ketoacidosis, right? I hope you understand the concept of acid and its conjugate base. Means when I have ATE anywhere, it is a conjugate base. Acetoacetate is a conjugate base of acetoacetic acid. So acetoacetic acid gives a proton and converts into conjugate base known as acetoacetate. Similarly, beta hydroxybutyrate is beta hydroxybutyric acid, right? If you have lactic acid, its conjugate base will be lactate. You have formic acid, its conjugate base will be formate. So whenever you have ATE, you are dealing with a conjugate base, okay? So what happens in diabetic ketoacidosis? In DK you have deficiency of insulin. If you have deficiency of insulin, what will happen to your blood glucose? It goes up. You have hyperglycemia, but technically you have glycopenia in your cells. Your cells are unable to utilize high amount of glucose circulating in your blood because of absolute deficiency of insulin. So what they will do, the body will start breaking down your fat cells. It will start breaking down your fat cells. In fat cells you have triglycerides, right? So lipolysis will be started and triglyceride will be converted into free fatty acids plus glycerol. So insulin deficiency, it promotes lipolysis, insulin excess promotes lipogenesis, and that is the way of increase in fat concentration in our body when you have high insulin levels in your blood. So when you have insulin deficiency, you have lipolysis, and this lipolysis converts triglyceride into free fatty acids and glycerol. This free fatty acids will undergo beta oxidation. Right? It will go into beta oxidation and will form acetyl coenzyme A, which goes into your Krebs cycle and produce ATP. So body is utilizing free fatty acids, and free fatty acids are converted into acetyl coenzyme A, which goes into your Krebs cycle and produce ATP. But because you have insulin deficiency, you have more and more lipolysis going on. So there will be a time when Krebs cycle will be saturated. If Krebs cycle is saturated, what will happen? You won't be able to convert acetyl coenzyme A towards your ATP. So this acetyl coenzyme A will be converted into ketone bodies. So this excess of acetyl coenzyme A is being converted to your ketone bodies, beta hydroxybutyrate and acetoacetate, and they are the conjugate base for corresponding acids, and that is the reason you have acidemia in ketoacidosis, which is diabetic in origin. Getting the point? From where you are getting high protons, you are not producing protons. This is a conversion reaction going on between the conjugate acid and a conjugate base, right? So this excess of acetyl coenzyme A is converted into beta hydroxybutyrate and acetoacetate, right? So there is a increase in proton ion concentration, and that is the way of understanding ketoacidosis of diabetic patient. Suppose someone is consuming lot of alcohol, continuous drinking of high amounts of alcohol. So what high amounts of alcohol will do? Alcohol directly increases acetyl coenzyme A, same thing will happen. Acetyl coenzyme A will be converted into this. Second, you have increase in NADH. You have increase in NADH. If you have increase in NADH, it inhibits your gluconeogenesis. It inhibits your gluconeogenesis. If gluconeogenesis is inhibited, your blood glucose goes down. This is a stress factor. Whenever you are in stress, your norepinephrine level goes up and your glucagon levels goes up in response to low blood glucose. Your norepinephrine and glucagon level goes up in response to your low blood glucose. What this glucagon and norepinephrine will do? It will again go to your fat cells and promotes lipolysis, right? Free fatty acids will be generated. This will be converted to acetyl coenzyme A. The Krebs cycle will be eventually saturated, and this same cycle goes on. So this is a final common pathway for both diabetic ketoacidosis as well as for alcohol. What happens with starvation? In starvation, you are not eating, your blood glucose level is down. If you are not eating, your blood glucose level is down, your norepinephrine increases, your glucagon increases. Both hormones works on your fat cells, promote lipolysis, free fatty acid formation, increase in acetyl coenzyme A. Eventually Krebs cycle will be saturated and you have formation of ketone bodies. So you have a final common pathway in all the three, right? Simple. So this is the pathophysiology of ketoacidosis in all the three states of diabetes, alcohol and starvation. Second is uremia. See, we understood that early renal failure produces normal aniongap metabolic acidosis. Whenever your GFR, it falls say around 15, 20, say less than 20, you are unable to excrete something like sulfates, phosphates and urates. Remember, what will the acid? Sulfuric acid, phosphoric acid, uric acid. So your proton ion concentration will go up You are unable to secrete the conjugate base in the urine. So whenever the GFR goes down to below 20, you have metabolic acidosis of high anion gap. Third will be lactic acidosis. Lactic acidosis. Lactic acidosis is of three types: A, B, D. We are not bothered about D. So we are not thinking of D. We are only thinking of A and B. So what happens to the when the glucose is metabolized into pyruvate, right? Glucose is metabolized into pyruvate, then it goes to your mitochondria. In the presence of oxygen, it turns into acetyl coenzyme A. It goes to your Krebs cycle, and ATP is produced. Correct? This is the final pathway for glucose metabolism. So you require oxygen. Suppose because of any reason there is absolute or relative deficiency of oxygen. So there is lack of oxygen. There is lack of oxygen. So pyruvate won't be able to go through this cycle of conversion into acetyl coenzyme A. So it will be converted into lactate. So this is type A lactic acidosis, where you have oxygen deficiency. When you have oxygen deficiency, your lactate levels will start increasing because pyruvate is not converted into acetyl coenzyme A. So what could be the reasons of oxygen deficiency? See, the problem could be in your lungs. Suppose you have pulmonary edema giving rise to hypoxia. ABG will show high lactate levels. Suppose you have pneumonia, consolidation, and your SpO2 is less, rather PO2 is less than 80. Your lactate levels will start rising. Suppose you have pulmonary embolism, again your lactate levels will rise. What else? Suppose there is a problem with your blood, you are anemic, unable to deliver oxygen to your tissues, your lactate level goes up. Suppose your effective circulating volume is less, you have lost lot of blood. So blood loss or plasma loss. In both conditions, your oxygen delivery to the tissues will be impaired and your lactate level will goes up. Suppose patient has vasodilatory shock because of sepsis. The same principle will apply. Your lactate levels will start rising. Suppose everything is fine, your lungs are fine, your blood is fine, but blood flow to the organ is impaired. Suppose you have, say for example, mesenteric ischemia, mesenteric occlusion or ischemia, or you have a limb where you have a embolus in the artery. So you have limb ischemia. So again, the moment you have ischemic insult, you have myocardial infarction, MI. So your lactate levels will start rising. So you just think it simply that how much important is lactic acidosis type A. In so many conditions you can have high lactate levels because of lack of oxygen, right? So what is now type B? In type B there is no problem in oxygen. Oxygen is absolutely fine. The problem is either the production of lactic acid is more, increased production, or you have decreased clearance. Increased production can be because of many drugs. The drugs act here at the mitochondrial level, right? So oxygen is fine, but there are drugs which are acting. So in your ICU, the most important drug is propofol, very widely used but causes remarkable lactic acidosis because it acts on your mitochondria. So thereby conversion of pyruvate to acetyl coenzyme A is impaired. Pyruvate is converted into lactate, right? Then metformin, or rather fenformin, which was a notorious drug which was withdrawn. Metformin, to a certain extent, when you use it in renal failure patients, can produce lactic acidosis. Then someone who is on NRTIs, HIV patient who is on NRTI, can produce lactic acidosis because of mitochondrial dysfunction. Someone who is taking linezolid for any staph aureus or MRSA infection, again this linezolid hits here, thereby promotes conversion of pyruvate into lactate. So these are the drugs which are implicated in increased production. Sometimes what happens is you have increased glucose flux or glycolytic flux. That means body is producing lots and lots of glycemic products. There are situations where your glycotic flux is high, such as malignancies. 3 malignancies you need to remember: leukemia, lymphoma, and multiple myeloma. In all 3 cases, because of increased glucose metabolism, right, this will be increased, ultimately Krebs cycle will be saturated. Whenever the Krebs cycle saturates, the pyruvate gets converted into lactate. So these are the 3 examples of malignancies where there is conversion of pyruvate into lactate. Then seizures, particularly status epilepticus. If you are having frequent seizures, patient can land up into lactic acidosis, not because of hypoxemia, but because of high glucose flux, right? The other problem can be of decreased clearance. Liver is the primary site of lactate metabolism. So if you have liver failure, you can have high lactate levels. Suppose you have renal failure, you will be able to not be able to excrete enough amount of lactate. So your lactate levels goes up. So that is the basic pathophysiology of type A and type B lactic acidosis. Type D is nothing, it's basically short bowel loop syndrome, wherein you have increased lactate levels. It's not important for us. The last one would be toxins. In toxins, it's simple. You have methanol, which converts into formic acid. Very toxic for our eyesight, for our nerve. So methanol gets converted into formic acid. Formic acid will be converted into H ions and formate, will give rise to your acidosis. Similarly, you have ethylene glycol. It gets converted into glycolic acid, which converts into glycate and H ions, and oxalic acid, which gets converted into H ions and oxalate, right? Ethylene glycol. Then you have propylene glycol. Propylene glycol basically can be there in when you use drugs like diazepam and lorazepam. The solvent is of propylene glycol. So when you use high doses of these drugs, right, you can land up into a high aniongap metabolic acidosis. And last is aspirin, salicylate. Remember, aspirin also causes respiratory alkalosis. We discussed in our last lecture. So this is how the pathophysiology of high aniongap metabolic acidosis is summarized. Now, how to evaluate in a algorithmic form? Suppose I have metabolic acidosis the anion gap is high. Okay, one correction which I wanted to add upon is that last time we discussed about delta ratio, and I told you that if the delta ratio is less than 1, it is pure high anion gap metabolic acidosis. If it is 1 to 2, it is a mixture of hagma and nagma, and if it is more than 2, it is hagma plus metabolic acidosis. Inadvertently what I did was, this is actually 1 to 2. Anything between 1 to 2 is hagma, less than 1 is mixed acidosis of hagma and nagma. So I regret this error. So just correct in your records that if your delta ratio is less than 1, it is a mixed acidosis of hagma and nagma. If it is between 1 to 2, it is purely hagma. If it is more than 2, it is hagma plus metabolic alkalosis. So suppose your anion gap is high. Basic thing which you can do is you can test for urine or serum ketones. If you have urine or serum ketones, you have 3 possibilities. You test for ketones. You have 3 possibilities. Either you have diabetic ketoacidosis, you have alcoholic ketoacidosis, you have starvation ketoacidosis. Alcoholic ketoacidosis, you have high alcohol levels in the blood, or you have a history of alcoholism, binge alcoholic. In diabetes, you have high sugar levels, high blood glucose levels. In starvation, this is a clear-cut history of patient who is on fasting for a very long period of time, giving rise to this. Suppose ketones are negative, still I have a high anion gap metabolic acidosis, so I order for my blood lactate. I see lactate. If lactate levels are more than 4 milliequivalents per liter, so I am dealing with lactic acidosis, which can be of type A or type B. So now you have to differentiate historically whether I am dealing with some lung issue, whether I am dealing with my blood issue, whether my blood supply to various organs is impaired. So you have to meticulously examine your patient and come to a conclusion whether I am dealing with type A or type B. If you have a liver failure patient, if you have a renal failure patient, it more or less fits into type B. If your lactate levels are normal, you see how is your KFT, your kidney function test. If they are impaired, increase urea and creatinine, we are dealing with CKD or uremia, which is giving rise to your high anion gap metabolic acidosis. If your lactate is also normal and your KFT is also normal, so probably we are dealing with toxins. So what to do in toxins? In toxins, we have to calculate osmolar gap. What is osmolar gap? Osmolar gap is measured osmolarity minus calculated osmolarity. You have a big formula, no need to remember, you can do it on your phones. You require sodium, right? You require your urea, and you have to divide it with various denominators, but it is measured osmolarity and calculated, what you calculate and what you are measuring. So this is basically an indicator of unmeasured solutes. Right? So with your serum osmolarity and your calculated osmolarity, you can come out to have a degree of unmeasurable solutes. So suppose it is more than 10, either it is a methanol, or it is propylene glycol, or it's a ethylene glycol. And if it is less than 10, it is salicylate. Fine. So this algorithm is fine. You have metabolic acidosis with high anion gap, check for ketones. If ketones are positive, you have 3 possibilities. Your history will tell you the diagnosis. If your ketones are negative, check for lactate. If lactate is high, you have either LA type A or type B. If your lactate levels are less than 4, you see creatinine. If creatinine is high, you have CKD. If creatinine normal, the only option left is of toxin. You calculate your osmolar gap. If the osmolar gap is more, the toxin could be methanol, propylene glycol or ethylene glycol. If the osmolar gap is less than 10, you have salicylate. So we come to the last part of metabolic acidosis, that how to treat. See, the treatment of diabetic ketoacidosis is very simple. All of you must be knowing. It is, first is IV fluids, then you have insulin, then you have correction of potassium. Correct? This is the way you go. You don't give insulin first, you give IV fluid first. You correct fluid deficit, you correct insulin, you correct potassium. What happens with starvation ketoacidosis? Again, IV fluids plus lots of dextrose you have to give to reverse that shunting of free fatty acids, right? In alcoholic ketoacidosis, apart from IV fluids and dextrose, you need to give thiamine. You need to supplement with vitamin B12 and various other things. Remember, you can have delirium. You need to manage it with benzodiazepines also when you have alcoholic ketoacidosis. What do you do for renal failure? If you have a high aniongap refractory metabolic acidosis in renal failure, the only option is either CRRT or hemodialysis, because most of these patients are stable with respect to acidosis. But if acidosis is predominantly severe, the only option is CRRT or hemodialysis. In lactic acidosis, you need to fix the problem, right? Fix the problem in the lungs, fix the problem in your blood vessels, fix the problem with your blood, right? In type B, you really can't do enough because you already have a bad liver and bad kidney. Same with toxins. Suppose you have methanol, right? Or you have ethylene glycol. In early stages, you can give fomepizole. In early stages, mind you, in few hours. But if they are late, in late presentation, the only option is hemodialysis. So in early presentation, you use fomepizole. In late presentation, you go for hemodialysis. Now, most of us have seen use of soda bicarb, NaHCO3. It is controversial. When you will study ABG in detail, acid-base disorders, you will encounter probably soda bicarb maybe in the minuscule subset of patients, right? It is not indicated. It creates many problems. What problems? The problem could be increase in sodium ion. So you can have hypernatremia. You have hypocalcemia, right? You can have increased in CO2. Right? So soda bicarb administration is generally not required in patients who are presenting you with metabolic acidosis. You correct the cause, generally you will not require use of sodium bicarbonate. It causes hypernatremia, hypocalcemia and increase in CO2 levels. Suppose someone has metabolic acidosis plus respiratory acidosis. So there is a severe acidosis. So one drug which you can give is promethamine. Promethamine. It is also known as THAM. THAM. Promethamine. It is known as THAM. It's a H-ion chelator. It binds to your excess H-ions. So suppose you have severe metabolic and respiratory acidosis, both, you can use a drug known as promethamine, which is abbreviated as THAM, and it's a H-binder chelator. In salicylate poisoning, you can use sodium bicarbonate. It's the drug of choice. In aspirin overdose, sodium bicarbonate is a drug of choice. So fine, we stop here, and by this we finish our metabolic acidosis. In next lecture, we'll try to finish off metabolic alkalosis. Thank you so much.